Here's a genuinely strange one to open with. Most antipsychotics have one dose range and one job, but there's a drug where BNF gives you two completely separate licensed dose ranges for the same tablet, one for predominantly negative symptoms, a much higher one for acute positive psychotic episodes. That drug is Amisulpride, and by the end of this you'll understand exactly why the dose itself changes what the drug is doing. Watch this. One pill, Amisulpride. Now follow the arrow down to a low dose and it's pulling one job, quieting the negative symptoms. Follow it back up to a high dose and it flips to a completely different job, settling the positive symptoms. Same tablet, same drug, two very different lives depending on where the dose sits. What kind of drug is Amisulpride? It's a substituted benzamide, the same chemical family as sulpiride, a much older drug still used in some countries. Brand name is Solian, though it's mostly prescribed generically. And here's something worth knowing before we go any further. This drug has no US license at all. Stahl's own textbook notes that even the active isomer is still only in early clinical testing over there. If you trained anywhere near US psychiatry content, there's a real chance you've simply never encountered this drug before. It's a UK and European staple that doesn't exist on US formularies. Licensing is refreshingly simple here because there's only one country's license to learn. There is no US indication to compare against. BNF gives Amisulpride two distinct licensed uses under the same drug: an acute psychotic episode, dosed at 400 to 800 mg a day up to a maximum of 1.2 grams, and schizophrenia with predominantly negative symptoms, dosed much lower, at just 50 to 300 mg a day. Notice this isn't off-label creativity. Both dose ranges are formally licensed indications in BNF. Flip this exam trap around from what you're used to. Usually in this series it's the US with the extra licenses. Here the US has nothing at all. So what's actually happening at the receptor level? Amisulpride is a clean drug pharmacologically, mainly just D2 and D3 antagonism, both with high affinity, plus a weak 5-HT7 antagonist action that may contribute to its negative symptom and mood effects. That's genuinely unusual. Most atypicals owe their atypicality to 5-HT2A antagonism, but Amisulpride barely touches that receptor at all. Its atypicality comes from something else. Stahl proposes it may be more selective for mesolimbic and mesostriatal dopamine receptors than for the nigrostriatal pathway. And I want to be honest with you, Stahl is appropriately cautious here, describing the negative symptom benefit at low doses as occurring for unclear reasons. We don't have a fully nailed down mechanistic story, and you shouldn't pretend to have one in an exam either. Now let's map that same receptor story onto the four dopamine pathways, because this is where the dose-dependent behavior from our hook actually plays out anatomically. Mesolimbic blockade helps positive symptoms, but remember from the dosing slide coming up, that really only kicks in properly at the higher end of the dose range. Mesocortical is the pathway behind the low-dose negative symptom story, though again Stahl is upfront that the precise mechanism here is unclear rather than fully worked out. Nigrostriatal is proposed to be relatively spared compared with older D2 antagonists, which is part of why Amisulpride tends to be reasonably well tolerated motor-wise at moderate doses. And tuberoinfundibular gets no such sparing at all. Full D2 blockade at the pituitary, which is exactly why prolactin problems are such a prominent and consistent feature of this drug across the whole dose range. Right, let's trace this together. Everything starts down here in the midbrain and four roads lead out from it. This one goes to the limbic system, mesolimbic. This one heads to the frontal cortex, mesocortical. This one drops into the striatum, nigrostriatal. And notice I'm drawing that one dashed, not solid, because Amisulpride is only proposed to spare it a little, not block it fully. And this last one runs down to the pituitary, tuberoinfundibular, no sparing there at all, which is exactly why prolactin takes the hit. Only two receptors really define this drug's core action. D2 and D3, both antagonized with high affinity. That's it for the core list, and that's genuinely the whole story compared with most antipsychotics, which usually have 4 or 5 receptors doing meaningful work. Stahl's own binding profile figure for Amisulpride shows essentially just these two boxes, D2 and D3, with nothing else registering strongly. Keep that simplicity in mind because it matters for the next slide too. This slide is really about what's absent. and that absence is the whole teaching point. Weak 5-HT7 antagonism is the only secondary action worth naming, proposed to contribute a little to the negative symptom and mood effects. Everything else on the usual antipsychotic checklist, 5-HT2A, H1, muscarinic M1, alpha-1, is negligible for amisulpride. That's exactly why it doesn't sedate much, doesn't cause dry mouth or blurred vision, and doesn't cause much postural hypotension. But it also means amisulpride doesn't get its atypical character from 5-HT2A antagonism the way risperidone or olanzapine do. It's atypical almost entirely through its distinctive D2-D3 selective low promiscuity profile. Absorption here has a genuine quirk worth knowing. Amisulpride shows two separate absorption peaks after an oral dose, one early around an hour in, and a second a few hours later. Absolute bioavailability sits at roughly 48%, lower than most of the other antipsychotics we've covered, and unlike the others in this series, food does matter here. A high-fat meal can reduce and delay the peak concentration, so timing relative to meals is worth considering when counseling patients. So how does amisulpride actually get into the brain? Unlike some antipsychotics that are lipophilic enough to just diffuse across the blood-brain barrier, amisulpride is relatively hydrophilic and positively charged at normal body pH, so passive diffusion alone doesn't get it very far. Instead, research shows it relies on active transport, pulled into brain tissue by an influx transporter called October1, and pumped back out by two efflux transporters, MATE1 and PMAT. Here's a genuinely interesting contrast with risperidone, which we covered in an earlier deck in this series. Risperidone is a classic P-glycoprotein substrate. Amisulpride, based on molecular docking studies, does not appear to interact strongly with P-glycoprotein at all. It's using a completely different transport system, and there's a real clinical payoff to understanding this. Research in Alzheimer's disease patients has found that changes in these blood-brain barrier transporters with age and disease appear to increase brain sensitivity to amisulpride. Older patients with AD psychosis respond to doses as low as 25 to 75 mg a day, way below the standard adult range, while still achieving high receptor occupancy in the striatum. That's a big part of why amisulpride dosing in frail, elderly or AD patients needs to start much lower than the standard schizophrenia range we covered earlier. Look at this capillary wall for a second. Amisulpride doesn't just slip through it, it needs help. Here's October1 grabbing the molecule and hauling it inside, but then MAT1 and PMAT show up on the other side and start pushing it straight back out again. It's a genuine tug-of-war. Now compare that to risperidone over here, just one pump, P-glycoprotein doing all the work of kicking it out. Completely different systems, same basic problem, getting kicked out of the brain. Distribution has another genuine outlier feature. Protein binding is only around 16%. Remember, most antipsychotics we've covered sit at 90% or higher, so this is a real departure, and it's worth actually unpacking what protein binding means rather than just quoting the number. When a drug circulates in the blood, some of it sticks to plasma proteins like albumin, and some of it floats free. Only the free, unbound portion is pharmacologically active. It's the only part that can actually leave the bloodstream, cross into tissue, reach receptors, and do anything. The protein-bound portion is essentially an active cargo, held in reserve. So what does a low-protein binding figure like amisulpride's actually mean in practice? Three things. First, displacement interactions, where one highly protein-bound drug knocks another off its binding sites and causes a sudden spike in free, active drug, are far less of a concern here because there's so little bound drug to begin with. Second, because such a large fraction is already free rather than protein-bound, changes in a patient's protein levels, say, from malnutrition, liver disease, or illness-related hypoalbuminemia, have proportionally less impact on the free drug concentration than they would for a highly protein-bound drug, where even a small drop in binding capacity can cause a disproportionate surge in active drug. And third, this actually connects directly back to the renal story from a couple of slides ago. Only free, unbound drug gets filtered by the kidney's glomerulus. A drug that's 90% protein-bound is largely too bulky to be filtered efficiently. Amisulpride, being mostly free in plasma, is exactly the kind of drug you'd expect to be efficiently filtered and excreted by the kidneys, which is precisely what we see, with roughly half of it leaving completely unchanged in the urine. Half-life sits at around 12 hours, which supports the standard twice-daily dosing schedule, And using our 4 to 5 half-lives rule, steady state is reached within a few days, nothing like the multi-week waits we've seen with some other antipsychotics. Now the single most important pharmacokinetic fact about this drug. Amisulpride undergoes minimal hepatic metabolism. It's predominantly cleared by the kidneys, with roughly half of a dose excreted completely unchanged in urine. That's a real flip from almost every other antipsychotic we've covered, where the liver does most of the work and the kidneys are secondary. Here it's the opposite. Hepatic impairment barely registers as a clinical concern for this drug, but renal function is everything. Hold on to that thought, because it drives the entire dosing and monitoring picture coming up. A short pharmacodynamics table, because this is a genuinely simple receptor story compared with the rest of the series. D2 and D3 are both straightforward antagonists, no partial agonism anywhere here unlike the aripiprazole family drugs. 5-HT7 antagonism is present, but weak, and its clinical contribution is proposed rather than proven. The main teaching point isn't complexity, it's that so few receptors are doing so much work, both for the antipsychotic effect and less helpfully for the prolactin problem. Dosing brings together everything we've covered. The two BNF licensed regimens sit side by side, 400 to 800 mg a day for an acute psychotic episode, up to a maximum of 1.2 grams, and just 50 to 300 mg a day for predominantly negative symptoms. Notice there's no hepatic impairment section in BNF for this drug at all. That's not an oversight, it's consistent with everything we said about minimal hepatic clearance. Renal impairment is where the real caution lives, and BNF and Maudsley agree closely on the numbers. Halve the dose if creatinine clearance is 30 to 60, drop to a third of the dose if it's 10 to 30, and below 10, there's simply no data, which in practice means this drug is best avoided in established renal failure. Contraindications here are more absolute than some of the other drugs we've covered. CNS depression, comatose states, pheochromocytoma, and prolactin-dependent tumors are all hard stops. That last one follows directly from everything we know about this drug's prolactin effect. Pregnancy and breastfeeding are both a straightforward avoid in BNF, not the more permissive benefit outweighs risk wording we've seen elsewhere, and for breastfeeding specifically, that's simply because there's no information available, not because harm has been demonstrated. The dementia-related mortality warning applies here exactly as it does across the whole antipsychotic class. Monitoring largely follows the standard antipsychotic panel, but two things deserve real emphasis here. Prolactin sits in Maudsley's high-risk major changes category, so treat it as a priority, not a formality. And QTC genuinely matters. There's a body of case report literature specifically linking amisulpride overdose with quart prolongation and torsades points, so ECG monitoring earns its place, particularly at higher doses or in anyone with cardiac risk factors. Renal function monitoring follows directly from the dosing slide, and here's a small but genuinely testable detail. BNF explicitly states that amisulpride doesn't affect blood pressure to the same degree as other antipsychotics, so routine BP monitoring isn't mandatory for this one specifically, which is a real point of difference from a drug like risperidone. Side effects: same BNF and MHRA frequency system as always. What's notable here is how short BNF's own common or very common list actually is, and what dominates it. Breast pain and abnormal orgasm, both directly prolactin related, alongside oculogeric crisis and trismus, both dystonic reactions. Let's actually unpack those two because the terms themselves are worth knowing cold. An oculogeric crisis is a sustained involuntary upward deviation of both eyes. The eyes roll upward and get stuck there, sometimes for minutes, sometimes for hours, and it's as alarming to witness as it sounds. Trismus is involuntary spasm of the jaw muscles, essentially lockjaw, where the patient can't open their mouth properly. Both of these fall under the umbrella term, dystonic reaction, and it's worth being precise about what that means. Dystonia is a form of extrapyramidal side effect where muscles go into a sustained, involuntary contraction, producing an abnormal posture or movement that the patient cannot voluntarily release. That's different from akathisia, which is more about inner restlessness and an urge to move, or Parkinsonism, which is more about slowness and rigidity. Dystonic reactions like these tend to happen early in treatment, are often painful or frightening, and respond quickly to an anticholinergic like procyclidine. That pattern alone tells you a lot about this drug's personality. Prominent prolactin effects, and dystonic-type extrapyramidal reactions rather than the Parkinsonism or akathisia pattern we've emphasized with other drugs. One more thing worth flagging directly. Since it's easy to assume every antipsychotic carries a blood dyscrasia warning the way clozapine does, I checked specifically, and BNF's Amisulpride entry lists no hematological side effects at all. No neutropenia, no agranulocytosis, nothing of that kind, and Maudsley doesn't flag one either. That's a genuine point of difference from clozapine, and worth stating plainly rather than assuming it applies here too. A long list of more serious effects, including cardiac arrest, sits in the frequency not known band, which ties back to that overdose and QTC concern from the monitoring slide. How does Amisulpride compare with the rest of the field? Weight gain and metabolic risk are both relatively favorable, better than olanzapine or clozapine. Prolactin is the standout problem. Maudsley places it firmly in the high-risk major changes category alongside risperidone and the first-generation drugs. QTC deserves real respect, particularly given the specific link to Torsades DE points seen in overdose case reports. Sedation is low, given the minimal histamine activity. EPS is proposed to be relatively low at usual doses, though remember that's a proposed mechanism, not a guarantee, and sexual dysfunction is genuinely common. Maudsley cites a prevalence of 60 to 70% for sulpiride and amisulpride together, almost entirely explained by the prolactin effect. 2 closing angles before dosing traps. NMS, exactly the same rule as every other drug in this series. It's a class-wide risk, and amisulpride's clean receptor profile doesn't grant it any exemption. Formulations here are genuinely limited compared with risperidone, oral tablets and an oral solution, full stop. No depot, no orodispersible option identified in BNF, and worth restating clearly, this drug simply isn't available in the US for any of its indications. One more thing worth flagging directly, because it's a common point of confusion. Amisulpride's dose-dependent behavior is not the same phenomenon as partial agonism in drugs like aripiprazole or cariprazine. It's still a full antagonist at every dose. What changes with dose here is which pathway gets meaningfully occupied, not the fundamental type of receptor action. Interactions look quite different for this drug, and that's directly downstream of everything we covered on the metabolism slide. Because amisulpride barely goes through hepatic metabolism, it largely sidesteps the whole CYP interaction web that dominates interaction discussions for most other antipsychotics. What actually matters instead falls into a few named categories. QT prolonging drugs first. BNF's own list includes other antipsychotics like haloperidol, sulpiride and pimozide, antidepressants like citalopram, macrolide antibiotics like clarithromycin and erythromycin, methadone and quinine. Combining any of these with amisulpride deserves real caution given its own documented association with Torsades DE points. CNS depressants are the second group. Alcohol benzodiazepines like diazepam, opioids, and other sedating antipsychotics such as olanzapine or quetiapine all add to sedation. Third, and genuinely worth remembering because it's easy to miss, amisulpride interacts with Parkinson's disease treatment. BNF specifically states amisulpride is predicted to decrease the effects of levodopa, and advises avoiding the combination, which makes obvious sense once you remember both drugs are acting on the same D2 receptors, just pulling in opposite directions. And finally, renal function remains the recurring theme from earlier in this deck. It's not a specific named BNF interaction, but anything that further compromises kidney function, like NSAIDs or ACE inhibitors, carries outsized relevance for a drug this dependent on renal clearance. Quick fire round. Does amisulpride have a broader US license like most of the drugs we've covered? False. It has no US license at all. Does BNF genuinely split its dosing by symptom profile? True. Does its atypicality come from 5-HT2A antagonism? False. That receptor barely matters here. Is it predominantly hepatically cleared? False. Predominantly renal. Is hepatic impairment a major dosing concern? False. BNF doesn't even address it. Renal function is what matters. Does it sit in the highest prolactin risk category? True. Is its dose-dependent action actually partial agonism? False. Full antagonist throughout. And is BP monitoring mandatory, like with risperidone? False. BNF specifically says it isn't needed for this drug. So back to where we started. Which antipsychotic has two entirely separate licensed dose ranges for two different symptom profiles? Now you know. Amisulpride with negative symptoms treated at the low end and positive symptoms at the high end. And now you also know why. Minimal hepatic clearance, renal dominant excretion, a genuinely clean D2, D3 receptor profile, and a prolactin risk that puts it right at the top of the class. And there it is again, the same pill we opened with, except now both arrows are fully labeled. Low dose negative symptoms, high dose positive symptoms. If that split makes complete sense to you now, this one's done its job.